IDA Mumbai branch. And it was a long wait, but we had to get our things right in order. And we are here now online with one of our very dynamic speakers, Dr. Vishal. And we felt we should start with a topic which is so dear to all of us, that is orthodontics in our general practice. So we'll be starting our program now, and I now request our Honorary Secretary, Dr. Rajesh Gaikwad, to please call upon the President. Over to Dr. Gaikwad.
Good afternoon, everyone, and it's our first TDE program. I will just call our dynamic president, Dr. Jeevan Shetty of IDA Mumbai branch, and it's over to you, President, sir.
Thank you, Dr. Rajesh. Welcome everyone to the first ever CD of 2002 by the Indian Dental Association Mumbai branch. And we are very happy to have Dr. Vishal, who's an excellent clinician and a speaker. So I hope this new financial year begins on a very high note for all of you. And we are going to have a lot of programs with the IDM Mumbai branch, a lot of CDs and other activities that will be happening. Do subscribe to our channel, and we'll be having a lot of other programs, so we'll keep informing you about them. Okay, you have a great session. Over to Dr. Das to take over from here.
Thank you, sir. Thank you, Dr. Jeevan. I would now like to welcome our own Dr. Suryakant Pawar, the Associate Professor and HOD of GDC Mumbai, as the moderator of our session. Sir has graduated from GDC Mumbai and has postgraduated from GDC Nagpur, and is currently doing his PhD under the MUHS University. He has a number of publications to his credit and has been a dynamic undergraduate and a postgraduate teacher. He has presented papers in multiple platforms, including national postgraduate conventions and national orthodontic conventions. He has worked as the nodal officer and committee member of the research committee set by the DMER Mumbai. We have a very, very powerful moderator today with us, Dr. Pawar. I would now request him to introduce our speaker and take over the session. Thank you, Dr. Pawar.
Thank you, Dr. Das. I hope I am audible.
Yes.
Yes, sir.
Yeah. So first of all, I would like to thank you, Dr. Das, sir, for taking this topic of interdisciplinary orthodontics. This is a very relevant and nowadays the need of the hour for dentistry. Nowadays, dentistry is not only any specialty dentistry, but it is a multidisciplinary and interdisciplinary dentistry. So once again, thanks Dr. Das sir for taking this relevant topic for all the practitioners who are associated with the IDA Mumbai branch. I would also like to thank all the office bearer, especially Dr. Jeevan Shetty, the President IDA Mumbai branch, Dr. Gaikwad sir, Secretary IDA Mumbai branch, for giving me this opportunity to moderate this session. So hereby, I would like to introduce our speaker today, Dr. Vishal Dhanjani. Dr. Vishal Dhanjani is a good clinician, and just give me 1 second. So to introduce our Dr. Vishal Dhanjani, who has successfully finished his post-graduation with multiple honors in 2007. And since then, he is intensively involved with clinical and academic activities. His areas of special clinical interest include growth modulation in children, non-extraction treatment modality, adult orthodontics, and aesthetic appliances with interdisciplinary orthodontics. Dr. Dhanjani has numerous awards and publications to his credit. He is an avid speaker and continues to be involved in education and promotion of dental health and orthodontic awareness through talks and lectures at various platforms. So without wasting too much time, I will request Dr. Vishal Dhanjani to take over and start his presentation. Thank you.
Thank you, sir, for those kind words of introduction. And a big thank you to all the office bearers of IDA Mumbai for this honor and opportunity. Without wasting any time, I would like to dive into the topic for the day. And a very good afternoon to everybody. It's after a very long time that the IDA is starting a new channel on YouTube, and which is committed to excellence in continuing dental education. Uh, so I'm sure it was have been a challenge, and challenges are have become a part of life, right? Challenges in our life are there from the day we are born. As we grow, life is full of challenges in our schools, in our as we in our colleges, and in our personal life on the sports fields. Life's challenges do not disappear at all. You will face them as you grow up, and they will exist till the day you exist, and that's how life is. But as it's rightly said, that life's challenges are not supposed to paralyze us. They are supposed to help you discover who you are. The last couple of years has been extremely daunting for the entire world, and more so with dentistry. 2 years ago, when the pandemic broke out, everybody was sure that dentistry, as we know it, has changed forever. Uh, People were afraid that we will have to shut clinics for a very long time. There were a lot of protocols coming in every day. There were new SOPs and new protocols. The equipment changed. We had to change. We were forced to purchase non-aerosol generating equipment. So it was a pretty challenging task. So dentistry has always been a challenging field, and the last 2 years truly have been a big ask from us. But now, as things are coming back to normal, life was much easier and simpler when we were in dental school, when we were taught about all these topics, individually. When you're taught about how to do root canals, to do crowns and bridges, to do flap surgeries like your fillings, implants, and occasionally, the life is joyous when you encounter such cases in your clinic, when you have a one-off thing to do. But more than often, it's not just these a single type of procedure. More often you are faced with situations like this, where there is a patient comes to you like this with a deep bite and spacing situation, or comes to you for a smile correction with poor smile aesthetics, or they come to you for a bridge in the lower arch with a completely collapsed upper arch, or a missing congenitally missing lateral incisor, asking for a space closure but with a very evident deep bite. So none of these situations come single, isolated problems. They always come uh, more often than not in a complex, overlapped way, and that is when you have to resort to something more. Maybe resort to the field of orthodontics. Now, for example, in this case, don't you feel that orthodontics would help in correcting the retroclined incisors and maybe redistributing the spaces to collect the spaces in a particular place where that it can be restored effectively prosthetically, or maybe to improve the tip and the torque of the incisors and of the canines, so that the laterals could be effectively restored aesthetically. Or maybe here, where there is a collapsed entire buccal maxillary occlusion, maybe to somehow get it in its place and correct the cant of the entire dentition. Or probably here, where there is a congenitally missing tooth, the orthodontics can be employed to either mesialize the buccal segment or distalize the buccal segment to create a space for a prosthesis in the canine in the lateral region. So let us understand how orthodontics can play an important role. Interdisciplinary orthodontics can empower modern dentistry, and that is the topic for today, initiated by IDA Mumbai branch. So I'm Dr. Vishal Dhanjani. Let us dive into the subject for today. See, as we saw, there are certain clinical situations that just cannot be handled single-handedly by one specialist. Such cases require a team effort. Okay, either from numerous specialities of dentistry and expertise from them. Such cases are called interdisciplinary cases. The critical factor in solving such cases is absolutely accurate diagnosis. After the diagnosis is accurately achieved, established, then you formulate a very focused treatment plan with proper treatment sequencing. This treatment sequencing is of utmost importance because there are multiple specialists, multiple types of procedures they need to be done. The sequencing will decide the success or failure of such situations. So now let us understand a very basic thing, one or two slides of what is our typical diagnostic sequence. The patient comes in, first we start with the chief complaint, take a detailed history of what their problems are, and perform clinical examination, which might include extraoral, intraoral examination. You do radiographic examination either by intraoral periapical radiographs or orthopantomogram, lateral cephalogram, posterior anterior cephalograms. Occasionally, we ask for specialized tests. We might ask for a CBCT, which is more common nowadays, or TMJ views, or something as simple as model analysis. You take models and perform a model analysis, either digital or analog. So all this data is combined together to reach a final diagnosis. Now, once you reach a diagnosis and identify so many issues with a situation, um, and you realize this will require inputs from more than one specialty of dentistry, right? Then you determine it as an interdisciplinary case. Now, in regular cases, you see a problem, there is a decay, it needs a root canal, you initiate it. But when the cases have multiple issues, the interdisciplinary approach has to be applied. Now, what is additional to this? So, once it's diagnosed as an interdisciplinary dentistry case, you start with formulating first a problem list. You identify all the problems in that situation, in the clinical situation, and then list out the clearly the treatment objectives. So these problems have to be sorted. How? This is exactly what you don't do any trial and error. You have to objectify the problems and make a list of treatment objectives. As per what your treatment objectives are, you list out the possible options of the treatment, because there are multiple specialities involved. Sometimes one problem can be resolved by more than one specialist also. So first you need to list out the treatment options. Once you've understood the options, taking the patient's thought process also into consideration, understanding the economic factors, time factors, and also what is the best possible outcome based thought process, you formulate a treatment plan as per all those, understanding all those treatment options. Once the treatment plan is formulated, it is very, very critical to sequence the treatment correctly. A certain specialty should work at a certain time to create the platform for the next specialty to work on the case. So that treatment sequencing is extremely important. We will look into some cases where which will understand we will understand this treatment sequencing and treatment process. Now, what is the role of the general practitioner when we're talking about so many multiple specialties? Yes, it is, when I say general practitioner, it's the main dentist who's received the case or done the initial diagnosis. They have the pivotal role in such cases. It is that doctor who has to coordinate between various specialists. He has to identify the role of each team member, right? And ensure that there's clear communication involved between the different team members. When two specialties or two specialists are working on it, uh, or they themselves are performing one procedure, they have to be sure that this is with objective answers. That this is the amount of space we are creating, or whatever is being done has to be very clearly communicated between each of the team members. So that's about interdisciplinary dentistry and how we approach it as opposed to any regular cases. Now, we will see a few cases to understand whatever I have said, because without seeing cases, it's very difficult to put things into perspective. The first case is a tooth size, jaw size discrepancy. That means everything morphologically looks normal, but simply the size of the jaw and the size of the teeth do not match. Hello? Am I audible, sir? Hello?
Yes, sir, you're audible. Yes, sir,
Yeah,
you're audible.
right,
Please go
right,
ahead.
right. So, right. So this is the first case. A young girl enters our office and she complains of poor smile aesthetics and gaps between her teeth. Now, on doing the clinical examination, we see a very mesoprosopic facial profile, facial appearance. maybe a little uroprosopic. But on the side profile analysis, the critical thing to observe here is that she has an obtuse nasolabial angle. That is one thing which you put a pin on. Once you see it's an obtuse nasolabial angle. As you do the intraoral examination, we see that there is spacing between her upper arch. There are retroclined upper incisors, right? There is an impacted 4-3, which is lingually placed, and there is an over-retained 8-3. By seeing the tooth size and the jaw size, you realize that though the tooth size are in proportion to each other, they are not in proportion to the jaw. That is why the spaces are there. And the the profile is already obtuse. The nasolabial angle is already obtuse. So it is not a case where you can close the spaces by retracting the anterior teeth. You will have to protract the posteriors, or at least as much as it is possible, especially because the upper incisor also retroclined and there is a deep bite, right? So we formulate a problem list. There is spacing in the anteriors. Let's simplify it, not to make it too much technical. There is spacing in the anteriors. There is a deep bite. The upper incisors are retroclined. You can see the incisal wear of the upper incisors. There is an impacted or lingually placed 4-3 and an over-retained 8-3. There is a high frenal attachment, and the anterior teeth are in disproportion. You can see that there are short crowns, right? There are short crowns, and the mesodistal width is large. So all these factors are contributing to the chief complaint of the patient, where she is unhappy with her smile. Now, what is the treatment plan? We need bite correction, obviously, to correct the deep bite. The spaces in the anteriors have to be redistributed. Now, since it's a tooth size, jaw size discrepancy, we are not looking at closing the spaces entirely by orthodontics, either by retraction or protraction, because it is we have to plan to redistribute the spaces, collect them in one place, and provide prosthetic rehabilitation in that area. Okay. Now, for that, you have to do model analysis to realize how much amount of space will be achieved on either sides. Also, the 4-3, which is lingually placed, has to be resolved. The surgical repositioning of the frenal attachment is required, and the prosthetic closure of all the remaining spaces after the space redistribution. And finally, the teeth disproportion in the upper anterior, in the aesthetic zone, in the smile zone, that needs to be worked upon. Right. So this is the treatment plan. Now comes the critical point of treatment sequencing. What is the sequence of this treatment, and which specialist is going to do which part? So the first 3 points of the treatment plan require an orthodontic resolution. So an orthodontic correction of the bite, orthodontic space redistribution, because the spaces are too much for them to be closed entirely orthodontically. The 4-3 has to be disimpacted. Got into its correct occlusion, and then there is this portion of spaces has to be coordinated by the orthodontic team and the restorative. So orthodontic restorative interdisciplinary planning has to be there. The second portion is the surgical reposition of the frenal attachments. At the right time, the orthodontist and the surgeon has to communicate to do the repositioning of the frenal attachment, but that also has to be timed. It cannot be done at a random stage. So there is a defined time where you need to do the surgical repositioning of the frenum. It can be done by the surgeon or by the periodontist. The prosthetic closure of the spaces, once the space redistribution is done, has to be performed. And then finally is the teeth disproportion correction. Now, teeth disproportion can also be corrected in 2 ways, either by restoratively or by periodontally. So by adding or by doing a gum repositioning. What needs to be done is as per the diagnosis, right? As per how the smile line is, where the teeth are at the end of orthodontic, what is planned, the orthodontic plan, and how much is the gum show on smiling, right? Now, in this case, we will see what was performed. So, firstly, the orthodontist started the procedures where the upper arch was strapped in by ceramic braces. The bite correction was initiated by torquing the incisors. Once the bite was sufficiently open, the surgeon was brought in to remove the 8-3. The extraction was not the big thing, but to open a window and give access to the 4-3, which was lingually placed, so that an attachment and traction can be placed from the lower right canine to the orthodontic wires. Then, because the bite was very deep, a bite plane was added in the upper arch at the right time, so as to provide some amount of help in clearing the bite. This is the procedure of, so now it becomes an orthodontic surgical situation where both the specialists are working on the case. As slowly the canine was brought into line, and while that is happening at the right moment, which is usually when both the incisors have had contact and there is no more space between them, there is no more midline diastema. At that point, the diastema is retained and the frenectomy is performed. So the surgical frenectomy by the periodontist is performed. You can see on the right figure. Once this is done, it looks much better, and the orthodontic part is continued. The bite is opened. The space, if you see as planned, is redistributed and collected distal to both the canines. That is so that so that they can be restored with as minimum of restorative work as possible, right? So we have to be prudent but minimalistic. So this is the corrected bite on either sides, and as you can see, the bite is open, the upper and the lower arch aligned properly. There is in the lower arch some self-cleansing space left. In the upper arch, they are collected distal to the canine so they don't affect the aesthetic zone. So this is a smile at the end of the orthodontic portion of this interdisciplinary case. As you see, the nasolabial angle and the obtuse the facial profile has been maintained. It has not been over retracted. Hence, the profile still looks pleasing. Now, this is the smile at the end of orthodontic. Now, if it was just a work by a single specialist, you should have been satisfied with this situation. But as it is planned with an interdisciplinary thought process in mind, we are looking at more things. So now, what is missing in the case? What is wrong with that smile? We know the proportions of the anterior teeth has to be around 80% in the mesodistal width to the incisor-cervical length. So that proportion has to be regained in this case. Let's see what it was in this case. It was 9/8, so 112% and not 80%. That's a vast amount of difference. No wonder the anterior teeth aesthetics is not looking great. So we plan a periodontal crown lengthening procedure where with this is now, so this was placed in front of the restorative and the periodontal specialist to see which is the right procedure to go in for. Because the smile was gummy, the periodontal was planned from the beginning itself. So this is the periodontal procedure, and after the crown lengthening, then the restorative procedures were performed where veneers were placed distal to the canine on either sides. Now here we are not looking purely at the proportions, because after achieving the mutually protected occlusion, the canine guidance and the anterior guidance, this is just to close the spaces since they are in the anterior aesthetic zone. So they were done accordingly, and this is the final result after the end of the entire treatment, right? She lost a little bit of so that's the smile at the end of the treatment, and this is her smile. This is a profile and a smile at the end of the treatment, right? So from here to here, but not just by one person's efforts, it's by a team of specialists where there was orthodontic, surgical, restorative, and periodontal procedures performed. That's the change in the smile, right? So this was about a case of tooth size, jaw size discrepancies. Now the next case is fairly straightforward. It's just about aesthetic finishing. Now a young girl again walks into the clinic asking for improvement in her smile. Now, if purely one would think like an orthodontist, what would you plan? You would observe it clinically. The profile looks good. You just have some spaces in the anteriors. You can just simply close the space. Now, if you think like purely a restorative dentist, then you would think of just increasing the mesodistal width of the anterior teeth to achieve space closure in the anteriors. But if you observe more carefully intraorally, that is not the only problem. See, if you the problem list goes more than that. There is improper torque of the canines. There is improper tip in the anteriors. The space distribution of the peg laterals is not correct. There is hardly any overjet for you to work on these appropriately. So, on observation and intraoral examination, the problem list which was formulated was peg laterals, anterior spacing, distally tipped canines, reduced overjet, and uneven gingival levels. So That's the problem. Is the treatment plan is to redistribute the spaces, correct the bite, individually reposition the peg laterals, and lastly, perform aesthetic finishing. Now, uh, the first person in, as per the treatment plan and sequence, was the restorative dentist. What was being attempted is to firstly restore uh, the peg laterals to the normal mesiodistal width. So that was what was planned first by the restorative dentist. So this is the at the end of the initial fillings. Now these are not the final fillings; these are the interim fillings. Now, if you observe, this is what the restorative dentist gave us. They gave us a big step between the laterals and the central incisors. Look at that step; it is almost a millimeter and a half. Okay. Now the question is whether this is right or wrong. So I would, if it would have been a live, offline session, I would have thrown it to the audience to understand this. Now, I think this is absolutely correct for two reasons. One is that the restorative portion was done by my wife, who's a restorative dentist, so she cannot be wrong. And the secondly, that's I'm just kidding. But more importantly, if you see, this is intent. This step of the central and lateral is intentionally kept so. Why is that so? Is because they have carefully observed and accounted for this. That is the gingival zenith line. We know the gingival zeniths, how they lie just away from the center. Also, the lateral has to be 1 millimeter below the gingival zenith line between the central and the canine. So that is what was accounted for, and intentionally in the interim restorations, the incisal edge was kept a millimeter and a half above. As the orthodontic procedure started, it was brought down, and the gingival zenith lines were made appropriate. So this is the beginning of the orthodontic part where upper and lower braces are placed. If you see progressively, carefully observe how the canines are torqued and the laterals are brought down, the anterior relations are made normal with normal contact points and connectors, and this is the final restoration done by the restorative dentist. So this is how the case ended after the orthodontic and the restorative procedure, carefully accounting for the anterior gingival levels. Thankfully, there was no periodontal procedures required at the end of this. And you see, there is a normal incisal contact, normal overjet, overbite, and the incisal the laterals are safe from any anterior excursions. So that's before, and that is after of. Again, this smile is achieved by the work of restorative and orthodontic procedures both. Okay. The next case is a more contemporary case of pre-implant orthodontics. Now, a young girl comes in for a poor anterior aesthetics, complaining of poor anterior aesthetics, and we observe a congenitally missing lateral incisor. Now, because of the congenitally missing lateral incisor, there is a buccal concavity in the bone as well. To add to that, there is a severe deep bite in the anterior, right? So, with this, we've realized that the problem list is pretty long. That is, there is a history of congenitally absence 2-2. The upper and the lower anterior crowding is seen with butterfly rotations of the two incisors. There is a 100% deep bite. There is a class 2 canine relationship, retroclined upper incisors, poor upper anterior inclinations, axial inclinations, and upper and lower anterior rotations. Buccal bone concavity is seen in the 2-2 dentoalveolar region. So all this needs to be addressed. The profile thankfully is pleasing, and the lower anterior facial height is normal. So we need to work on everything simultaneously. This was the radiograph, her radiograph, and you see there was a Maryland just before, it was removed just before she saw us, the photographs were taken. There's a very thin Maryland place in that region, right? So after the radiographic examination, whenever there is a missing tooth in the anterior maxilla, we have two options. Let us explore the treatment options when there is a missing central or a lateral incisor. Let's consider lateral incisor in the upper anteriors, right, in the anterior maxilla. So now here the treatment options are either space closure using canine substitution. What is canine substitution? Is when you mesialize the canine into the space of the lateral, and then with restorative procedures turn the canine into looking like a lateral, and you mesialize the premolar into the canine space, and again do restorative procedure to make it look like the canine. So that is called canine substitution, space closure while canine substitution. Or you reopen the space and replace it prosthetically, either by something like a Maryland or a tooth-borne, any tooth-borne bridges, or a single tooth implant. So these are the ways of handling missing teeth in the anterior maxilla, either space closure with mesialization or distalization, and reopening and restoring it. So now what happens when we do canine substitution? Let us weigh the pros and cons of each of the two options. When we do a canine substitution, there are certain advantages. Yes, if there is a congenitally missing lateral and the canine comes almost in the place of the laterals, you essentially have solved your positional problems to a large extent. So in case if it's congenitally missing, not lost due to decay or trauma later in life, many a times the canine will erupt right in the place of the lateral incisors, which reduces your work by a large amount. There is no prosthesis, no artificial prosthesis. It is just the reshaping of the teeth or minimal restorative work. It is much more economical. It is a much more conservative approach. There is less future maintenance, and it is an all natural approach. So that is the pros of a canine substitution. But what are the cons of a canine substitution? You have to ensure that there is a color match. There has to be a morphology match. The gingival margins have to be placed correctly. We cannot, the gingival zenith line has to be taken care of. The harmonious margins have to be taken care of. The canine root prominence in when smiles where the lip line is high, the canine root prominence will be very obvious. So in such cases, we have to be careful while performing canine substitution. The size of the canine should not be too large from the contralateral lateral incisor, so that it does not look very uneven or it does not involve a large amount of restorative work. There will be some excursive interferences on lateral excursions due to the palatal cusp of the first premolar on the side where the canine substitution is performed. If you chop off that if you redo that palatal cusp, there will be sensitivity. Or also if there is a lot of enameloplasty done on the canine and the first premolar, and this requires a long-term retention because one might expect some amount of relapse tendency. As opposed to this, the other option is tooth-supported restoration. When you open up a space in case there is a missing lateral incisor, that any ideal prosthetic option is the one which is the least invasive and satisfies the aesthetic and functional objectives of the patient. In such situations, it could be a cantilever bridge, it could be a full coverage fixed bridge, it could be a resin bonded fixed bridge, or it could be a single tooth implant. More recently, we have understood that the single tooth implant has very quickly become the treatment of choice with the advent of better materials, better procedures, and better understanding. Because, and for certain advantages as enumerated here, the adjacent teeth are untouched in single tooth implants. It's the most conservative approach. Success rate of 90% is seen over 10 years. This is some data which was provided. There is immediate temporization is possible. This should be, however, applied with caution because it is extremely technique sensitive. It needs a lot of expertise and a very focused team approach. There are other factors to be considered when you are doing implants in the anterior maxilla, like the angulation and the position of the roots, the smile line height, the width of the interdental space, amount of bone available, length and width of the implant, how the position of the implant is to the respect of the basal bone, the remaining gingival thickness and its transparency. And you have to see how is the patient profile. Is he committed or she committed to the future maintenance of the teeth? As it is purely in terms of operative terms, we know that the surgical classification of a single tooth gap in the anterior maxilla is already in the advanced section, whether it is with bone deficiency or without. So already it is a case which requires a lot of focus and attention. Now, in such situations of missing teeth in the anterior maxilla, what is the role of the orthodontist? The role is to create space and to perform pre-implant orthodontics, right? But what is pre-implant orthodontics? Is it just pushing the teeth away to create space? Is it that simple? No. Successful pre-implant orthodontics is that which creates the platform for ideal three-dimensional placement of the osseointegrated prosthetic implant, resulting in long-term function and stability, right? So in other words, Successful pre-implant orthodontics is that which creates a success, the platform or the environment for a successful implant in the long run. So the success of the implant is directly the success of the pre-implant orthodontics. So it is not very straightforward. It requires a lot of pre-operative treatment planning. Now, from all the three specialties, the restorative, the treatment planning, the objectives of the restorative treatment plan has to clearly define the aesthetic parameters for the implant restoration. What we mean by aesthetic parameters is how do you want the smile line? Where do you want the smile line to be? The margin to be, the incisal edge of the as per the gingival exposure during smile, during talking. So the aesthetic parameters for the implant restoration has to be initially defined by the restorative dentist. He should also define the potential risk factors for aesthetic shortcoming. As per the contralateral, lateral, or the adjacent teeth proportions, you have to define what could possibly make it incorrect for at the end of the treatment. So it has to be, the aesthetic parameters have to be defined first. As per the surgeon, the surgical parameters, like he has to define the aesthetic objectives such as the harmonious gingival margin, make sure that the papillae are intact, and observe or preserve the convex contour of the alveolar crest. That is the objectives in treatment planning or from the surgical part. From the orthodontic perspective, the orthodontist has to identify the potential failure points, the anatomic or the operative. So once you know the failures, you know how to avoid the failures, you know how to make it successful. The orthodontist needs to plan the movement so as to create an ideal 3D, three-dimensional, ideal implant site for ideal three-dimensional placement. Once all this planning is done, it is then you can go ahead and start executing the treatment plan. Now, in this case specifically, the plan was done for aligners, and the entire plan is, as we know in aligners, is all digital. And this Invisalign was used for this treatment planning. As you can see, the space opening is performed with distalization of the buccal segments in that region. Once the buccal segments are distalized, there is individual distalization of the molars, premolars, and the canine, and the right amount of space is created, 7 millimeters for the lateral incisor. Also, while we are doing this, there is in the plan there is overcorrection of the deep bite, which is planned accordingly. The Bolton's analysis, the model analysis is fair; it does not show any problem. So, though this is outside the purview of this lecture due to the paucity of time, pre-implant orthodontics is an entire lecture by itself. Here we have to condense the entire essence of pre-implant orthodontics is considering firstly the timing of the implant placement. The timing of the implant placement has to be appropriate, age appropriate. You cannot do it too young. Till the vertical and the horizontal growth of the child is still there, you cannot perform implants. So you can start at the right time so that you're not too early, neither are you too late for the implant placement. So the timing is of essence. Next is the three-dimensional implant site development, which you have to consider the coronal space development and the apical space development both. As per the crown, as per the right proportions, you have to create the amount of coronal space. As per the size of the implant and the location, you have to create the right amount of apical space. The post-orthodontic occlusion is important. You cannot afford to have a deep bite. As in any case, the anterior occlusion has to be light. That is the post-orthodontic occlusion which you want to achieve. And if there is a gap between the orthodontic finish and the implant placement, the retention protocol has to be customized. And as per the duration, either it can be removable or a fixed retention, depending on when the implant placement is planned. Now, in this case, as per the digital plan, we went ahead and performed made the aligners and got the proceeded with the treatment, the opening of the space. As you can see on the right side, that the lateral incisor space is increasing over the months of the aligner placement. Also, there are some technical parameters of the aligners which was changed with time. The attachments were placed and removed as per the axial inclination correction over time. And this is at the end of orthodontic treatment. We have achieved the right amount of space. The entire 100% deep bite has been corrected, and we have achieved a class 1 molar relation on either sides, right? At this point, the implant planning was done on the three dimensional on the CBCT. The implant planning was done, and then the implant placement procedure was performed. This is entirely surgical. The surgeon raised a flap, saw the buccal bone defect, they placed the implant, and this is a platform switch implant or something like that. I'm not the person who did this. So the surgeon was performed the implant placement. Then a bovine graft was placed, a xenograft was placed here, and a porcine membrane was used to cover this graft. And then sutures were placed, micro sutures were placed. And this is how it looked at the end of surgery, 1 day after surgery, right? There's some amount of gingival margin repositioning which has happened after these sutures were removed. And this is the post implant placement. If you can see, the retainers are in place already, right? A temporary retention plan was made where an Essex type of a retainer with a Pontic was placed and given to the patient. So even when the healing phase was on or the osseointegration was on, this is how the patient looked, and she was fairly satisfied. She came back after the temporary restoration was performed for the implant. Then the doctor surgeon again went in to perform the restorative phase where a puff of gingiva was created and to create the right gingival margin effect. And this is how it was finally performed. And this is the final restoration of the implant. And this is how the patient looked at the end of the treatment after the entire phase of orthodontic, restorative, and surgical phase. Right? So orthosurgical restoration and rehabilitation of the entire case. So from there to there, and that's pre-implant orthodontics. As I said before, it is a very huge and a vast topic, but this is the gist. This is how we performed it in this case. Now, the final case for today, we are talking about adjunctive orthodontics for prosthetic rehabilitation. A young man has came to us with issues with his smile, and he was not able to chew because he had no teeth in the lower arch. When we looked into the mouth, this is what we found. This is the kind of occlusal cant which he had, a very occlusal situation. And when we observed that the dentoalveolar heights on two sides of the maxilla was very different. On one side it was small, on the other side was very wide, very large. When we looked and we realized that there is a complete extrusion due to long-standing missing teeth in the lower arch. There is complete dentoalveolar extrusion on the right side of the upper teeth. There is a missing upper tooth, and what you cannot probably see very well is there are lower two premolars which are entirely in scissor bite with the upper arch. So that was the situation, a very difficult situation. A lot of other options were thought of. So the problem list is mutilated dentition with multiple missing teeth and drifting. There is excess dentoalveolar height in the first quarter. The scissor bite with lingually placed 4-4 and 4-5, and there is cant of the occlusal plane and smile, right? So that's the problem list. Now, what would a treatment plan be for such a case? You cannot. The only other thing other than you can think of is probably extraction on entire one side of all the teeth and then restoring it. Other than being so aggressive, there was no other plan individually by any individual specialty which could come up with a plan. So again, we had to resort to a multidisciplinary approach, and the orthodontic plan was interesting because how do we work on such an extruded dentoalveolar segment of the upper right quadrant? So what you do is, with the advent of microimplants, is easy to perform intrusion of the posterior teeth so as to achieve a clearance in that region. So it was a difficult situation. We attempted with two microimplants were placed, one from the buccal and one from the palatal. There was a wire placed on the two teeth on either sides of the space of the site, and intrusion was begun to perform. It is a very slow process to intrude multi-rooted teeth. It is a very arduous process, but it with time it gives results, especially to us. Look at the occlusal plane at this point. There's almost like two different occlusal planes. Don't worry about the gum collection or the gum fold next to the brackets which you can see. That gum fold will get there'll be recession of the, I mean, the clinical crown will be regained with time. But this is the kind of intrusion we were able to achieve. Once this was performed, a continuous wire was placed and the rest of the teeth were also intruded. Look at the difference. Look at the clearance achieved in the lower arch, right? So then regular orthodontics was performed. The arches were aligned. You can see in this photo that the lower the two premolars, which were completely in scissor bite, were brought out, and a normal looking bite was achieved. The hygiene was a little bit of an issue for the patient, but this is where we finished and got into retention of this case. Now that's the occlusal plane at the end of orthodontic treatment, and then it was handed over to the prosthodontist or the restorative dentist who placed the posterior teeth. So that was the smile at the end of the treatment. So evened out from both sides, and if you see, we in fact completely corrected the cant of the occlusal plane. In fact, slightly overcorrected it, which is what is required in situations like this. So such treatment results were possible only because of orthodontic, surgical, and restorative interdisciplinary approach to correct such a situation. So that was the approach. And similarly, so we saw 4 cases. Other than this, there are other situations where interdisciplinary approach can be utilized effectively, like full mouth rehabilitations, periodontally compromised cases, posterior implant site development, and adjunctive orthodontics for prosthetic restorations. So these are the other areas where interdisciplinary approach can be a real game changer to achieve fantastic results, which otherwise may not be possible by a unidimensional approach towards dentistry. So teamwork is the critical factor. It is teamwork that is the fuel which allows common people to achieve uncommon results. To summarize the plan, the entire lecture, we have realized that contemporary practices involve a wide variety of clinical situations. In trying to deliver the best possible treatment outcome, we have to employ more than one specialty for the same case, either in sequence or in tandem with each other to achieve great results. Either ways, the modern dental practitioner needs to wear many hats in order to attain success in interdisciplinary case. So we have to educate and make our eyes tuned to understanding the nitty-gritties of such interdisciplinary cases, because with modern dentistry, interdisciplinary dentistry is not really an exception. It has rather become the norm for modern dental practice. With this, I would like to conclude my lecture. A big thank you to everybody who has attended this lecture, and a special thanks to IDA Mumbai. And I would be failing in my duties to if I have not thanked the office bearers, Dr. Atin Das, Dr. Jeevan Shetty, Dr. Rajesh Gaikwad, and more importantly, Dr. Suryakant Pawar, who's a member from my own specialty and my senior, a great clinician. Nice to have him. It's an honor to speak in front of him as the moderator of this session. I'm open to questions if there are any.
Thank you, Dr. Vishal. Your presentation was such a wonderful presentation, so I don't have to speak anything. It was self-explanatory. The cases you showed,
Thanks.
the 4 cases you showed, with first case of tooth material arch line discrepancy, the second case of peg-shaped laterals, the
Hello?
third case was congenitally missing. Yes.
Can you hear me?
Hello. Yes, sir.
Hello?
Yes, sir.
Yes, sir. We can hear you.
Yes, sir.
Yes. And the last case of adjunctive orthodontic prosthetic rehabilitation. So all those cases were self-explanatory. You explained them very well with stepwise treatment planning, treatment sequencing, and then treatment execution. Before any questions comes up, I would have a simple doubt. In your second case, you have chosen restorative correction first for the laterals, peg-shaped laterals, and then you went for orthodontic treatment. So,
Yes.
what was the reason? Why not the other way? That is the orthodontic treatment first and then restorative. Can you please explain?
Yeah, so it was. It's a very good question. Thank you for the question, sir. So we could. So the peg-shaped laterals were not in the center of the spaces. So and also when we are doing orthodontics in such situations, we are always afraid if we will overclose the space, because the mesodistal proportions had to be first determined as per the width of the central incisor. When we do a restoration as per that, we have already blocked the mesodistal space which will be required for the final porcelain veneers. So once that mesodistal space is locked in by the interim restorations, we are not afraid while doing orthodontics to overclose the space or anything like that. Uh, having to do adjustments in the porcelain veneers is more difficult. Doing it in the orthodontics is much easier. So block the amount of space required and then do orthodontic movement to achieve the right finish, so that the finish of the veneers is fantastic in that case.
Oh, okay. So that was thank you, Dr. Vishal, for
Very good
explaining
question, sir.
so nicely. Yeah. My second question is, you mentioned about the essence of timing. The time is very important in pre-implant orthodontics. So what is
Right,
your
sir.
recommendation? That
Right.
orthodontic treatment is going on and it's a long treatment. And again,
Right.
after orthodontic treatment, if you go for implant, then that lag has waiting period of implant. So how you suggest to manage the time so that patient will get as early as possible the treatment?
Right. So the timing matters in two aspects. One is timing in terms of whether there is any growth of the patient left. So when there is vertical or horizontal growth which is left, then finalizing an implant may not be possible. So timing matters in that sense. And the other time which you're saying in terms of during the treatment, at what point before you finish, that time it matters. So firstly, the timing of the vertical growth, typically, though there are many ways and there are very differing opinions in terms of what is the right time for finishing, performing implant placement. Till recently, it was believed just the vertical growth. So you perform two consecutively taken lateral cephalograms. When you take two consecutive
Okay.
lateral cephalograms spaced between 6 months, and you observe no vertical growth, you would expect the growth to have ended, because vertical, as we know as orthodontists, the vertical growth is the last to finish. So if you observe on cephalograms, two consecutive cephalograms 6 months away, there has been no vertical growth. So vertical growth has been accounted for. But since nowadays there is also an aspect of horizontal growth, I'm not an implantologist, but I did speak to some implantologists where they say the horizontal growth also has to be taken. So some prefer it a little later. For us, a benchmark could be a little using these parameters to see if the growth is over or not, after which you can place the implants. So we can't hear you, sir.
Yeah, sorry. Am I audible?
Sorry. No. Yes, sir.
Yeah. Thank you, Vishal. Thank you, Dr. Vishal. One more question has come
Most
up.
welcome,
The
sir.
participant is asking, you mentioned about the posterior implant site development. Can you
Yes,
elaborate
sir.
that?
So posterior implant site development is of two types. If there is a congenital, if there is a long-standing missing tooth and the adjacent teeth have drifted, so the space has to be opened up. Now, depending on the restorative plan, the quality of tooth movement can be done in two ways. You can either open it by tipping the crowns, or you can open it by moving the roots, right? Depending on the restorative plan. So that is one posterior site development, implant site development. The other type of posterior implant site development is called the implant site switch. Now, if there is a long congenitally missing tooth in any posterior region, there is atrophy of the bone which happens, more so from the buccal side, right? So once there is atrophy of the bone which has happened, there is one more method of regaining implant site or bone in that region, is when you walk a tooth through that area. So when you move a tooth through bone, it leads to generation of some amount of bone material. So now that is called an implant site switch. When the actual missing tooth is in one place, but you move a tooth in that region just to switch the implant site and create bone in that area. So those are the two types of posterior implant site development which is possible, where orthodontics plays a role.
Yeah. Thank you for explaining so nicely, Dr. Vishal.
Most
As
welcome,
there
sir.
are no more questions, I would like to say that you rightly mentioned that nowadays dentistry is not conventional dentistry, but it is modern dentistry. And for best possible results for patient benefit, it has to be a team effort. And when all the
Yes.
specialties, along with the general practitioner, when they are working as a team, definitely it will be beneficial best possible ways to the patient, and it is beneficial for our profession, that is the dentistry. So
Sir.
I thanks once again, Dr. Vishal, for such a wonderful presentation. And now I would like to hand over the mic to the IDA office bearers.
Thank you, Dr. Pawar. Thank you, Dr. Pawar, so beautifully moderating our session. Dr. Vishal, I'm sure today's presentation has been an eye opener to all our practitioners. I totally agree. I do a lot of full mouth cases, and in most of the cases, the benchmark, the start of any full mouth case is orthodontics. Today, in the world of conservative dentistry, I always start, I do a lot of lecturing, and I always start with a very common saying that most of us learned in dental colleges of the Divan's dictum that we must preserve what remains than to
Obviously.
replace what is missing. And I think so the orthodontist is one head of us who can really change the tooth position, bring them into a more optimal position so that we can effectively restore them with minimal intervention. And Vishal, you have really beautifully presented. Thank you so much for enlightening us.
Thank you, sir.
On
Thank you, sir.
behalf
It's
of
honor.
IDA Mumbai branch, let me present you this certificate. It was an honor to have
Thank you,
you
sir.
on with us. Thank you,
Thank
Vishal.
you,
We
sir.
will be
Thank you,
sending
sir.
you the printed certificate over. Next
Thank
to
you, sir.
our very dynamic moderator, sir, you've taken up time from some of your busy schedule of GDC to come here and moderate our session. Thank you, sir, so much for having here and being moderating our session. Thank you so much, Dr. Pawar. And now I
Thank
hand
you.
over the
Thank
mic
you.
to Dr. Rajesh Gaikwad to give the vote of thanks to our presenters.
Good afternoon, everyone. I think it's a wonderful presentation by Dr. Vishal Dhanjani, and definitely this ortho is the only specialty usually is practiced by. It's called as a specialty branch, and definitely Dr. Vishal now had cleared most of the doubts for the general practitioner. It's orthodontics means usually we think it is related to cosmetic aesthetic, but he insisted and he pointed out that it is mostly functional. So so usually this ortho specialty definitely if we come together as a interdisciplinary way, it will be very useful for the general practitioner to treat the cases. So, as a secretary IDA Mumbai branch, I would like to thank Dr. Vishal for deliberating this his excellent lecture, and similarly, Dr. Suryakant Pawar moderating this session very intelligently and clearing all the doubts of all the all those who are attending this. I will. I'm again thankful to my president, Dr. Jeevan Shetty, Dr. Das, CD convener of IDA Mumbai branch, Dr. Gaurav Shetty, co-convener CD for IDA Mumbai branch, then all my EC members of IDA Mumbai branch and office bearers, then Dr. Neil for and his team for the social and digital background backup for this IDA Mumbai branch, and for uh, again I will be thankful to all the participants for listening this lecture carefully. Thank you very much.
Thank you, Dr. Gaikwad. Thank you, everyone, for viewing us today. We will soon come back on the 14th of April to celebrate the World Art Day. We have a special program for all of us showcasing the art talent in our dentists. On the 14th of April, it will be an online program. And we will very soon announce our offline program. Since all the restrictions have been called off by Government of Maharashtra, we will soon declare our first offline program immediately after the World Dental Show, because we are now all aiming at the World Dental Show on the 23rd and 24th of April. We'll have our next program immediately post the World Dental Show. Thank you once again, everyone. Thank you, Dr. Vishal and Dr. Pawar and the entire IDA team. And
It's a
thank you,
pleasure.
Dr. Neil, for
Pleasure.
all the support.
Thank you. Thank you very much.
Bye and good afternoon to all.